Good morning, everyone. We'll see about getting started if everyone's caffeinated enough. So thanks for joining us on day 2 of our VCBH annual conference. So to start us off this morning, we're excited to have Dr. Mark Levine as our first speaker. Dr. Levine was appointed Commissioner of Vermont's Department of Health in 2017. And prior to that appointment, he was a professor of medicine at UVM, as well as Associate Dean for Graduate Medical Education in our UVM's College of Medicine. Dr. Levine also actively practiced general internal medicine with particular interest in health promotion, disease prevention, public health, and health policy. So please join me in welcoming Dr. Levine, who will be speaking on the lifetime approach to tobacco prevention and cessation among Vermont women and girls.
Thank you, Stacey. Everybody hear me okay? Great. I always love when Steve invites me to these. We get a nice chance to showcase some of the stuff we have going on in Vermont. But we're quite humble, and we show the blemishes as well as the successes. I'm going to try to focus mostly on Vermont, though there'll be some national data that I do present as well. But what we're going to try to do is start with a little demographics, epidemiology, some statistics of what's going on with women and girls in Vermont. Then move on to an area we're especially concerned about, which is pregnancy. And then talk a little bit about policy and initiatives to really try to reduce tobacco use and the next generation for tobacco prevention policies. A lot of the data that I'm going to present in the early part of this talk is going to be focused from the Griffiths, which is the Behavioral Risk Factor Surveillance Survey for adults, and the Youth Risk Behavior Survey, YRBS, for youth. There's also a little bit of information from the National Survey on Drug Use and Health. So in this first slide, we're basically just focusing on this is Vermont. I know some of you are not from Vermont, but even for those who are, this may be illuminating. Basically, we know that we are a rural state, if you haven't figured that out. And rural states tend to have actually people who have lower income living in the rural areas. They may have high poverty rates. They may also have less in the way of educational accomplishment. In Vermont, we also are the 4th oldest state, which alters our demographics slightly. We used to be in the top 3, and I'm not sure who inched us out here. Our rates of alcohol and cannabis use actually are higher than the nation by and large. But when you look at cigarette smoking, though we are higher than the nation, we are certainly significantly high in this region of New England. Vaping, as you see, for adults in Vermont is a little bit lower than the rest of the country. Now here we're going to focus ourselves a little bit on female youth and use of various tobacco products. So in the blue, you can see kind of any tobacco use. And you see that the peak years are certainly high school through age 25 to 44. Notice that those are childbearing and child-rearing ages, so we're particularly focused on that. If we look at traditional, I don't know if in this conference you're calling them combustible cigarettes or what, but basically not so much in our youth, though certainly through the later school years they do increase. But definitely peaks at ages 25 to 44, after which there's a drop off. And then in the greenish color is vaping, which of course is our big concern in high school, rates going up to 18%, and a steady decline as you go into the post-high school years in Vermont. Obviously, it's obvious why we focus so much of our prevention efforts on our youth. Also, if you look on the right side of the slide, you'll notice that 9 out of 10 Vermonters who are women began smoking before the age of 21, with the majority of those before 18. Now let's look at adults versus youth females. Basically, if you smoke, basically you are more likely to use alcohol, cannabis, or vape, and less likely to smoke as a youth. For an adult woman in Vermont, you're less likely to use cannabis or alcohol, but you'll note the cigarette smoking and e-cigarette use on the right-hand side are not statistically significant differences. We know there's a significant correlation with mental health quite often, and smoking and other adverse behaviors. If you look at youth versus adults, you see kind of the same pattern, but much more accentuated in the youth part of the slide on the left. So feeling anxious, reporting poor mental health, feeling sad or hopeless, being involved in an emotionally abusive relationship. In comparison, looking at adults on the right-hand side, these numbers are still true, but they're at a little lesser degree. And we've added one further category of caregiver, which obviously is more relevant at those higher ages, which also makes it more likely. Now, there's a definite importance to looking at the relationships and correlations with substance use as well as tobacco. We kind of include that in all substances in Vermont, but obviously when people think substance use, they're much more thinking alcohol, opioids, cannabis, etc. And as you can see in this slide, on the left side of each set of bar graphs in the sort of greenish color, goldish greenish color, is the rate among either youth, 5%, or adults, 14%, for cigarette smoking. And we look at then some of the characteristics of women that might have a disproportionate impact on that. So for the youth, having flavored tobacco before age 13, vaping, binge drinking, cannabis use, reporting poor mental health are all higher than that sort of average level of 5%. For the adults, we see the same kind of pattern described. We look at everything in aggregate. For vaping, we again see, as I showed on an earlier slide, very significant percentage in high school females, much more so than on the right side of the slide for adult females at 4%. But then when we start looking at the associations with some of these behaviors, so if you're in high school and currently vaping, you're more likely to smoke, to have used flavored tobacco before age 13, to use cannabis or binge drink or report mental health, and pretty much the same kind of pattern for the adults, but as you can see, much less dramatically so, although we're starting with a lower percentage, so obviously there's still 2 to 3 times the rate in those groups. What about the impact on women's health in general? Well, There are some tobacco-associated disorders that we definitely see in Vermont, like in other places, women are more likely to have. Basically, we've highlighted 3 of these here: arthritis, asthma, and cancer. Interestingly, males have a higher rate of cardiovascular disease than women, which is probably consistent with a lot of other data. However, the women have these other conditions at a much higher rate here in Vermont. Looking more nationwide, women who smoke, obviously, everyone knows, have a higher mortality risk, and there's a survival benefit associated with smoking cessation. We all know that the risks of various cancers is quite high, although the risks for cardiovascular disease and respiratory infections, et cetera, is significant by all means. This national data really focuses on the fact that you can see pretty nice drop-offs for women who have chosen to quit smoking and are considered in the formerly smoked category on the right-hand side of the slide. Now, separate data from some other literature tells us that if you quit before you reached age 45, you are reducing your excess tobacco-associated mortality by as much as 90%. If you quit in the 45 to 64 age range, you still have a benefit, but it's about 2/3 as opposed to that significant high benefit that the slide showed. Let's talk about smoking cessation in our Vermont women. As you can see, for the adults in the blue, the rate of quit attempts has trended downward between 2012 and 2021. Pretty consistent drop-offs there. Looking at youth between 2017 and 21, we do see that quit attempts have actually increased. If you then look on the right side of the slide, you'll see some characteristics of female youth that basically, compared to males, they significantly more often try to quit use of tobacco products, and they were more consistently asked by a medical provider if they smoke. It's always dangerous to talk about CPT codes, especially if you've been a practicing physician, because CPT codes are often used as a surrogate for behaviors that occur in an office setting, assuming that the behavior occurs and the CPT code is recorded as is. That's often a leap of faith, and sometimes the documentation requirements, et cetera, make this challenging. But at least when we're comparing year to year, we're comparing the same problem with the data. And you'll notice that since we've been working to try to decrease our rates among Vermont Medicaid insured women since 2014. And as you saw from some of my earlier slides, that's a particular audience we wanted to key in on. So the blue represents brief counseling by the code. The maroon is more intensive counseling. And unfortunately, you'll see that beginning in 2019, there was a drop-off in the use of these codes. Although notably in the gold, dentists became a shining light for reasons that we may want to take credit for, but I hesitate to take credit for completely. But it's a great thing. Any dentist in the audience, kudos to you. So what explains this decline? Again, challenging, but everyone knows the years that COVID existed, and they do parallel these years, and so much in our society changed during those years. And when we look at other substance use, et cetera, we find significant problems because of the pandemic. There's also an issue about sort of the aligning or misaligning or not aligning of performance measures that talk about smoking and smoking cessation versus asking about tobacco use at every visit. So we don't have a clear sense, but certainly a disturbing trend by this measure, not by all measures. Let's look at what women are doing when they say they are trying to quit. Patches are leading the pack, if you will, followed by Chantix, followed by nicotine gum. You'll notice again, 2019 was sort of a great year and then things started to trend downwards. But on the right side of the slide, you'll see that it's really the middle-aged and older women that are embracing these strategies more than the younger, and that all forms of nicotine replacement therapy, with the exception of gum, women seem to embrace them more than males. We're going to look at a little more data now, but we're going to really focus in on the pregnant population because it is a significant problem here in Vermont that we've been concerned about for some time. No matter which year you look at between 2016 and 2021, fudging the math a little bit, Vermont is about twice the rate of smoking in pregnancy compared to the national rate. Very unfortunate, but very consistent, unfortunately. Even in years where rates are decreasing both in Vermont and nationally, we're still stuck at twice the national level. We're at 90.4% on that slide. So what contributes to this? Well, first of all, we again talk about rurality. Rurality is associated with higher rates of smoking. It's also associated with higher rates of low socioeconomic and educational attainment. And we've already shown that those are not protective. They are risk factors. We also have a high vaping rate before pregnancy, 8% in Vermont versus the US rate of 5%. Our use of alcohol and cannabis during pregnancy, we are certainly not proud of either. And then finally, the use of substances other than alcohol and tobacco, we have a significant rate of that in Vermont as well. Now, on this slide, we're looking at vaping in the 3 months before pregnancy, which you can see in the blue is on the rise during the 5 years that are presented on the slide. The rate of cigarette smoking actually comes down. But vaping is on the increase. Is one of the reasons for that the use of vaping as a tobacco cessation tool, as opposed to another adverse habit? Well, sort of looking at the right-hand side of the slide, clearly there are Vermonters who have been switching to vaping as a quit method for smoking cessation during pregnancy. Question is, how much of that explains the use of vaping or not? So our teams are actually looking at this data. First of all, they're trying to look at something the slide doesn't show, which is dual use, cigarettes and vaping, because that may explain some of the women who are vaping to try to get off of the cigarettes, but also looking specifically at the use of e-cigarettes for a smoking cessation tool. So hopefully more to come on that at a future time. Here's some of the reasons why our work with the Medicaid population is so important. As you can see on the left side of the slide, if you're Medicaid insured, you have, and a woman who was pregnant, you have a 10 times greater likelihood of smoking during pregnancy than if you're not insured by Medicaid. On the right-hand side, it doesn't help if you're trying to quit because you're only about half as likely to quit smoking before the second trimester compared to the pregnant Vermonters, to other pregnant Vermonters not insured by Medicaid. So obviously, this provides fertile ground for looking for other strategies to try to be successful with this population. Looking at outcomes, and small gestational age being a significant, important outcome that we can actually measure here. If you're Medicaid insured and you smoke during pregnancy, you're about twice, perhaps closer to 3 times more likely to deliver a baby who's small for gestational age. That also will incur more costs at about double the cost in Medicaid healthcare costs for the infant in the first year of life. So obviously, and I want to thank, and you probably can't read it at the bottom of the slide, but I want to thank Steve Higgins and Dr. Shepard and Slade also for some of the data that we collaborated with them on to present this. So what's being done about this? Well, obviously, the bodies that are setting guidelines for family practice and OBGYN practitioners say all the right things, which you would hope they would. This is an important time in a woman's life, and to try to increase the best outcomes for themselves as well as for their new child. So obviously advising cessation of tobacco products in any form, providing motivational feedback, individualized care, and pharmacotherapy to support quitting are high on the list of recommendations. And making sure that this occurs throughout the time that the person is having prenatal visits, as well as postpartum. Obviously, this can be challenging when there are so many other issues to address during that time period. Are people trying to quit? Well, it turns out that almost 80% have used some kind of cessation strategy during pregnancy. That's the good news. The bad news is the strategy they're using the most is the one that's least likely to be successful. So that's trying to quit on your own, 68%. The success rate of that, probably around 5%. So not the go-to methodology, though commend people for trying for sure. How does it work out when you sort of get through all the data? Well, among pregnant Vermonters who smoke cigarettes, 40% of those smoking before pregnancy quit before the last 3 months. But then when you start looking at what happens after giving birth, only 35% of those who quit smoking during pregnancy resumed again within those first 6 months. Very challenging to deal with. Needless to say, another attestation to the addictive properties of nicotine. So this, unfortunately, is another attempt at looking at some CPT codes and other pharmacy claims. But when we start to look at the use and provision of tobacco cessation counseling codes, it's very low among pregnant Vermonters, which is in the blue line, and in OB/GYN providers specifically, which is in the gold. But having said that, use of pharmacotherapy as assessed by claims for pharmacotherapy among pregnant Vermonters has increased nicely, although we're seeing a little tendency towards decrease in that latter year. Again, is this COVID influenced? Is this other factors? We don't really have a lot of insight into that. But again, we don't want to make assumptions about the coding habits of practitioners being the most accurate and sensitive way of understanding this problem. So having shown you some of the challenges, both in the pregnant and non-pregnant populations, the concluding part of the talk is really looking at the initiatives that we have underway. So efforts include increasing provider capacity, prioritizing women's health, increasing perception of harm from tobacco products, and using things like contingency management, which is an evidence-based intervention that provides motivational incentives to treat individuals living with substance use disorder and support recovery, and using that in this arena. We have a program called Strong Families Vermont, which provides home-based visiting programs with nurse practitioners or family specialists, which is a major way of trying to help, especially the at-risk populations we've been talking about at those important junctures with the new mother-child and family-child dyad that has occurred in their life, looking at a lot of social determinants, etc. The Vermont Blueprint for Health is a program that uses community health teams and supports primary care in numerous arenas, whether it be mental health, whether it be counseling for substance use, whether it be nutritional, exercise, you name it. That program for quite a number of years now has had a women's or a pregnancy intention initiative, which allows for greater degrees of screening on a consistent basis across primary care. And this blueprint is throughout all of Vermont and the majority of practices, and really tries to increase healthy behaviors as part of healthcare reform. The National Council for Mental Well-Being, again, shows that there a little bit about our behavioral health initiative to prioritize tobacco treatment. The goal here is, I think for so long, people who smoke but have other disorders, the smoking kind of takes the back seat. It's like, oh my God, if we try to have them quit smoking, they're never going to succeed with their alcohol use disorder. They're not going to succeed with whatever other disorder we're managing. This sort of tries to turn the table on that a little bit and tries to say, you know, people are dying from cigarette smoking, and we ought to pay attention to that and not just sort of allow that to go on and make like it's a less of a priority. So the Tobacco Control Program is really starting a new contract with national experts in improving wellness through addressing this particular issue. There's lots of media campaigns we do in public health. And basically, if you have a campaign that's effectively designed, that's one of the evidence-based strategies we use to increase the perception of harm, whether it be tobacco use, vaping, you name it, and also to increase the motivation to quit. So on the left side, we have One More Conversation, which has been developed in concert with our clinician community to really focus on pregnancy and all of the potential misuses of substances that can adversely impact that pregnancy. Long-standing campaign called Counterbalance, which is really directed at and involving our youth to highlight how there's a conscious effort on industry to focus on them and to focus on some of the characteristics demographically of them. The Unhyped campaign actually looks at vaping specifically, and again, in youth, connects with them in social media in ways that are quite crisp and powerful. Some of the things on the right side you might be familiar with for quitting in terms of tips from former smokers who have gone through serious illness or even death. 802 Quits, which is our campaign for providing specific tools to assist people in quitting. And females actually enroll in many of our programs, whether it be the Quit Line or other quit groups, at a rate higher than males, which is great. They also enroll in some of our quit smoking workshops. Again, you'll see this gradation on the bottom of age, where the older women are more likely than the younger women to embrace these. So obviously, a lot of our efforts are at trying to increase the lower end of the age group's use of these. Call out Steve Higgins and his team here, who've collaborated with us for quite a long time in randomized controlled clinical trials to really look at the efficacy of providing motivational financial incentives and promote cessation among our pregnant Vermonters. I dare say I cannot in one slide summarize all of this work, and I'm going to really just give you the punchlines, which are on the slide. If you're a pregnant Medicaid-insured Vermonter and you receive some of these motivational incentives, we're talking, gift cards, things that have financial value but not specifically cash, and are done in an evidence-based manner with the appropriate level of incentivization provided, you may have a 6 times a greater likelihood of quitting smoking than just using best practices for smoking cessation. On the right-hand side, with colleagues around the country, that has been shown to actually have a return on investment that's quite significant, that you can see illustrated here. About 12 times, the return on investment was 12 times the cost of the incentive. Sorry, Steve, that I summarized your life's work in 1 minute. Just finishing up here. We have a lot of tobacco retailers in Vermont, and tobacco and poverty and low socioeconomic status go together. And the darker colors just show that there are plenty of tobacco retailers in the wrong places when it comes to the population we're trying to help. Part of this is not only where the retailers are located, but how much does the pack of cigarettes or whatever they're buying cost. So we can see that there's quite a range and a difference in mean prices. But the bottom line is that in Vermont, like in most states, there is no floor that's been set, and there's also an allowance for discounting. So what better way to help a susceptible youth but to provide a cost incentive to smoke? So initiation becomes easier, maintenance of smoking becomes easier, and cessation becomes more challenging, especially knowing that most states still have menthol cigarettes, which have been targeted at our youth and other specific populations. So what are the kinds of initiatives that are going on? Well, with the UVM Health Network, we're certainly dealing with tobacco treatment protocols. Steve has done a lot of work with trying to, with the electronic health record, make this an activity that would occur consistently if you've identified tobacco use as an issue, so that you don't have to opt in and be provided this benefit, but you actually have to opt out and decline the benefit. Also, the use of contingency management, as on the slide, could certainly benefit from growth across a broader population. Looking at our hub and spoke system in Vermont, which is treatment system for opioids, we have now expanded that to covering all substances, whether it be tobacco, alcohol, you name it, as well as mental health. And we are now in the process of dispersing funds to use contingency management for the management of stimulant use disorder, where it has been shown to be evidence-based effective. But why not use it for the tobacco at the same time? So we will be encouraging that extension of contingency management. There's a lot going on in the rural settings with regard to quitline. Pharmacists are now tobacco treatment providers in Vermont. So we're supporting a pilot with one of the chains of pharmacies in Vermont to see what kind of work we can do with them to expand their use of cessation tools and pharmacotherapy with people walking into the pharmacies. And then we would expand that across other chains as well. And then finally, I don't want to get into the nuances of Medicaid and 1115 waivers, but clearly using this as a way to implement contingency management. The states of California and Washington have included that in their Medicaid waivers. So there are discussions underway in Vermont. Last slide is basically just, again, looking at what kind of policy initiatives could we have as we enter a new legislative season. restricting flavors and specifically menthol. This would be, I guess, the third go-round, but maybe the second. No, the fourth, I'm told. But this is the year it would probably be successful because it seems to have built some momentum. I don't want to call it before it happens. We'll see in the next legislative session. Nicotine caps for tobacco products, you're going to hear about in the next talk. Certainly something that any state could consider, knowing that the FDA may address it, but it may take a long time while they're addressing it. And then finally, we just talked about restricting coupons and having a minimum floor price. And certainly expansion on all of our kinds of media and other campaigns to encourage cessation and to discourage use of vaping and tobacco. So thank you very much for your attention. And if we have time, I'm happy to take questions.
We have 1 or 2 minutes for questions for Dr. Levine, if there are some, before we move to our next presenter.
I'm also struck by the high quit rates of pregnant people when they find out they're pregnant, but then also the high rates of relapse after giving birth. And it just seems to me that that's a really great opportunity for smoking cessation, maybe in the Strong Families Vermont program or well baby visits or something. Yep. Is that something that Vermont is considering or has considered?
Yeah, so the Strong Families Vermont program, the whole key to the success of that is just a trusting relationship with a new family, a new mother, and trying to uncover as much as is going on. Some of that is going to be economic, some of that's going to be mental health, some of that's going to be finding some of the adverse childhood experiences like an incarcerated person in the family, etc. But a lot of that is looking at substance use. And one thing we've tried to do in Vermont is really make the word substance use mean more than just non-tobacco substance use. Try to include tobacco in that. That's sort of the thesis for our whole Substance Misuse Prevention Council, which looks at the whole continuum of substances. And as we all know, nicotine is that early addictor that happens in the early teens and other things follow. So I think, just like the national slide I showed on mental health well-being, making sure tobacco is front and center, and it's not like, well, you've got a problem with alcohol, we just have to address that. It's really like, well, alcohol may kill the person from cirrhosis decades and decades later, but all of the complications from their tobacco use are going to occur way earlier.
Thanks for taking time from your busy schedule to be
Sure.
here with us. And I learned things that I didn't know about. And the one that I'm very impressed and excited about is about the pricing in disadvantaged communities and the tobacco industry. What I should say is we just submitted an R01 application, NIH, 2 days ago, where we're trying to model this effect with respect to the nicotine reduction. And so we bring down the nicotine content in cigarettes, you decrease, getting in the weeds a little bit, you decrease the reinforcing value of cigarettes, but then the tobacco manufacturers are always out in front on this sort of thing. So they know if you decrease the price, then the unit price would still, for cigarettes, would still support a decision to smoke. So I'm thrilled to see that you're on that, and anything we could do to help study it or quantify it, I'd be thrilled to participate. So, yeah.
Thank you. The fact of the matter is, like you say, they are always one step ahead. We have people who are in the back of the room who've been addressing these issues for years, and brilliant strategies we come up with, and we even get the legislature and governors to pass these strategies. But then something else comes up, another idea has to happen because they figured out a loophole.
Oh, absolutely.
Part of what we're doing in terms of that last slide is really also working with our tobacco control people in the state, because a lot of times what happens is we set a law about banning internet use or banning use purchase of something in a store setting. If you don't actually have an enforcement mechanism, you may lose the battle there, even though you've got a very nice looking law and excise tax and everything else. And in cannabis, we're actually going the opposite way. So in cannabis, it's not only legal, and no controversy about that at this point, but the potency level of the THC is spiraling out of control. So the expectation is that the product you purchase, even from a state sanctioned site, is going to have a very high potency level. Otherwise, you're going to go back to the purchasing habits you had before it was on the marketplace. Nicotine, we're trying to go the opposite way, but it's in the face of that. And of course, so many users are now getting acquainted with the use by vaping THC, often co-vaping with nicotine and THC at the same time. And it's going to really be a very curious phenomenon where one thing is becoming way more addictive and the other we're trying to tamp down on at the same time. Good luck.
The only thought I would add to that is many more people are dying from cigarette smoking than cannabis.
Yes,
So,
for sure.
All right, thank you. Thanks, Dr. All right, our next presenter in this session is Dr. Jen Tidey. Dr. Tidey is the Associate Dean for Research and Professor of Behavioral and Social Sciences at Brown University's School of Public Health. She is also affiliated with the Center for Alcohol and Addiction Studies at Brown, where she helps to lead a NIDA T32 training program and is the director of the CAAS Behavior and Health Laboratory. Dr. Tidey has a productive research program aimed at understanding and reducing the high rates of tobacco dependence across a number of vulnerable populations. And the title of her talk this morning is Response to Nicotine Product Standards for Cigarettes Among Women and Girls. I'll let Charlie do the tech support. Thank you. Right, thank you. Does this have a pointer by any chance? Yes, okay. Thank you. I'm delighted to be here to talk to you about a national nicotine reduction policy, which is a policy that the FDA is considering, built on, it's actually amazing that we've gotten so far into this meeting without talking about this, because the University of Vermont Center on Behavioral and Health, led by Dr. Higgins, has been so involved in building up the evidence base for this policy, including many of the people in this room. So I'm sort of amazed that I'm the first person in this conference to be talking about this, but I'm happy to be describing it to you and looking into whether women and girls might have a different response from men and boys to a national nicotine reduction policy. So these are my disclosures. All my funding is from NIH. It doesn't come from tobacco or any other product companies. So we've heard yesterday about tobacco use among women. The prevalence of smoking among US men is higher than among women, but that, as we've heard, that gap has been narrowing over the past decade or so. And women are generally less successful at maintaining long-term smoking abstinence than men. They have higher rates of relapse during cessation. And except for varenicline, which appears to be equally effective in men and women, treatments such as nicotine replacement therapies and bupropion seem to be less effective in women.
And one reason for that may be that there's a body of research showing that men are more sensitive to the pharmacological effects of nicotine than women, whereas women seem to be more sensitive to sensory motor aspects of smoking. So that may explain, at least in part, why NRT, which is a nicotine, like a nicotine patch that replaces the pharmacological effects of nicotine, but not the sensory motor aspects of smoking, may be more effective in men. And so interventions that focus solely on nicotine replacement by that logic may also be less effective among women. Nicotine potential national strategy for reducing cigarette use and cigarette dependence among U.S. adults and youth, making it easier for people who smoke to quit smoking. And so the idea is that by reducing the nicotine evidence base for this. And there are numerous trials of very low nicotine content cigarettes have demonstrated that reducing the nicotine content of cigarettes to a very low level does actually reduce smoking, as I'll show you in a minute. But given previous research showing that women and girls may be less sensitive to nicotine dose, will women and men differ in their responses to a nicotine reduction standard? So this is just a diagram of the cigarettes to show you that we're not talking about reducing nicotine a little bit. It's actually would be, 85 to 97% reduced. And so this isn't the kind of reduction that you can make up, you can compensate for by smoking more. And it's not the light cigarettes of the 80s, which were just appeared to be delivering lower nicotine yield because of engineering of the cigarettes with holes in the filters that made them appear to be lower nicotine delivery. These are cigarettes that use genetically modified tobacco that is lower in nicotine and would be basically impossible to compensate for. And this is a list of many or most of the major trials of spectrum valency cigarettes, starting with the Donnie et al. 2015 study, which is a dose response study. And I'll show you the outcomes of that in a moment. There was an important study to look at, well, if we're going to reduce the nicotine content of cigarettes across the United States, should this be done all at once? Or should it be done gradually over time? You might think that would be easier for people to adapt to, although potentially more difficult for cigarette companies to do a step down in nicotine content. But it was important to look into whether gradual or immediate reduction would be more effective. Dr. Schiffman did a study in non-daily smokers, so many people who smoke in the United States. Sorry. Technical.
Sorry. I believe we can fix it very quickly.
What will we do with that?
Sorry to break up your train of thought.
Okay, I'm not doing anything wrong, am I?
No.
Okay, pressing things. Okay, non-daily smokers, it also works in non-daily intermittent smokers. There was a study looking at the combination of very low nicotine content cigarettes and nicotine patch, and both of those approaches were effective, but nicotine patch did not increase the efficacy of very low nicotine cigarettes. I did a study in people with schizophrenia and bipolar disorder. So you might think that if any group of people might have an adverse reaction to reduced nicotine cigarettes, it will be people who have very high rates of smoking and very high nicotine dependence. But we also found that very low nicotine content cigarettes reduce smoking in people with schizophrenia and bipolar disorder without having adverse unintended negative outcomes. Dr. Higgins' 2020 study that I'm going to show you outcomes in a few slides from now looked at effects across 3 vulnerable populations: women who are socioeconomically disadvantaged, people with opioid use disorders, and people with affective disorders, depression and anxiety disorders, and also found that very low nicotine content cigarettes reduce smoking with virtually no negative consequences. And there have been a couple other trials in low SES or people with affective disorders. There's been one trial in adolescents who are daily smokers. It was a 3-week exposure study and also found that very low nicotine content cigarettes reduce smoking in adolescents who smoke daily. And then there is a current study that is under review that I won't talk about those outcomes. So this is that first row of the prior slide I told you was a dose response study published by Donnie et al. In the New England Journal of Medicine 2015. And you can see that when people were randomized to cigarettes with 2.4 or less nicotine content, that they reduced their smoking by about 5 to 6 cigarettes per day compared to people with higher nicotine content cigarettes. And by the way, all the people in these trials were not trying to quit smoking when they entered the trial. And this research cigarettes were provided for free during the trial. But the outcome is total cigarettes. So not just the number of research cigarettes, but did they sort of cheat by using cigarettes that they might have purchased at, just out in the natural environment. So the outcome is total cigarettes per day, research plus non-research cigarettes. And we saw nice dose response and reduction in biomarkers of nicotine and tobacco exposure as well. And this is the outcome from the gradual versus immediate reduction study. The gradual is shown in the red line. This is the control group. They received normal nicotine content cigarettes. And you can see that the immediate reduction was the more effective approach in terms of reducing cigarettes per day, in terms of reducing biomarkers of exposure to tobacco toxicants, and in terms of days abstinent during the trial. So people who received the immediate reduction in their nicotine of their cigarettes were more likely to be abstinent during the study than people who had it gradually reduced over time. So overall, these studies are very consistently showing that very low nicotine content cigarettes, using these cigarettes for 6 or more weeks, leads to a reduction in smoking rates over that time. And these effects extend to several vulnerable populations, including people with depression, people with anxiety, people with schizophrenia and bipolar disorders, and people with socioeconomic disadvantage, people with opioid use disorders. And there have also been some secondary analyses to look at people who also use cannabis and people who also drink alcohol. And the effects are very consistent across all of these groups. But there has been no evidence of compensatory smoking, or and mood disturbance has been very minimal or not at all. But what about men versus women? So if women are less sensitive to the pharmacological effects of nicotine, maybe they will continue to smoke very low nicotine content cigarettes, just like they smoke higher nicotine content cigarettes. On the other hand, if women are less sensitive to the pharmacological effects of nicotine, maybe we won't see this cheating that I referred to a few moments ago that occurs when people are using very low nicotine content cigarettes. So we see, with regard to cheating, a lot of people do it, but they only do it a little bit. So there's a high percentage of cheating, but it's only like 1 or 2 cigarettes per day. But maybe women will be less likely to do that because they will find very low nicotine content cigarettes, just as satisfying as higher nicotine content cigarettes. And if we see a difference between men and women, I thought maybe it'll be particularly evident in vulnerable populations where you might expect to see more cheating because they're more dependent. So that sort of was the underlying thinking of this presentation. There have been a few trials of very low nicotine content cigarettes in women versus men, some acute laboratory studies that did find that women were less sensitive to the effects of nicotine content on positive subjective effects of smoking and on relief of abstinence-induced negative affect than men. There was also a study that found no dose by gender interactions. That was a secondary analysis by Joanna Streck of some of Steve Higgins' group's data. And one secondary analysis found that women had a larger decrease in nicotine exposure in response to VLNCs than men. So some mixed findings. This is one study by Faulkner et al. That shows, these are doses. So this is the high dose, this is the low dose. And you can see that women were pretty across the board. They liked them all sort of 40 on a presumably 100-point scale. They rated them all similarly, whereas men, you see a nice dose response curve where they liked the higher nicotine more than the lower nicotine, as you might expect. And then this is pre-smoking craving levels in women and men. And you can see that craving levels before smoking were high and then reduced after smoking to about the same extent across doses in women. So again, there's no dose sensitivity there. Whereas men, you see pre-smoking craving is high, it goes down with a low nicotine content cigarette, and it goes down more with a higher nicotine content cigarette. So there's more dose response. So what will we find in our studies? This was the Higgins et al. 2020 study that a lot of people, as I mentioned in this room, were involved in. It was a 12-week exposure to very low nicotine content cigarettes, or I should say research cigarettes that varied in nicotine content from 15.8, which is normal nicotine level similar to conventional cigarettes sold now, a 2.4 milligram per gram, which is a very low nicotine level, and a 0.4 milligram per gram tobacco, which is an even lower nicotine level. And the three populations, so this was a large study, 775 people, about evenly broken into three groups: disadvantaged women of childbearing age, adults in treatment with opiate use disorders, and adults who have affective disorders, meaning current or lifetime depression or anxiety disorders. So after a baseline period in which they received their usual brand cigarettes free of charge, they were randomized for 12 weeks to receiving one of these research cigarettes. They received enough to completely substitute for their usual brand cigarettes. And then we did some follow-ups. And what we found in this trial was a nice, just very reminiscent of the slide data I showed you from the Donnie et al. Study, a very nice dose-dependent reduction in total cigarettes per day. Again, this is the sum of research cigarettes plus any cheating of non-study cigarettes. And that was echoed in the study cigarette effects. We saw a dose-dependent reduction in nicotine dependence on two measures, the Fagerstrom measure and the Wisdom measure of, so that was great. And what about, I should have said, what about women and men? Women versus men. So this was a secondary analysis. I want to shout out to Mike DeSarno, who did this for me, sort of, even though he was overloaded on other things he was doing. So really appreciate that. But I just asked him to add a moderator to the analysis, add gender as a moderator and rerun the same analyses. And this is what we found. And what we found, to cut to the chase, is really no evidence of differences in women versus men. So the D indicates a dose effect, a main effective dose on total cigarettes per day. There was actually a dose by gender interaction effect on study cigarettes per day, but it was opposite of what I might have expected. So in fact, you see a stronger dose dependent relationship in women than we did in men, where the 0.4 and 2.4 had similar effects. We saw a significant effect of dose on breath carbon monoxide level. That's a level of tobacco toxicant exposure. And we saw a significant gender difference in that men had higher CO levels than women, but there was no interaction between dose and gender. And dose effect on urinary cotinine, that's a measure of nicotine exposure with no evidence of an interaction. And likewise, we saw dose effects on cigarette dependence and on craving with no evidence of a gender interaction. And then a gender effect on withdrawal with higher withdrawal scores in women, but no interaction and similarly no effect on craving for usual brand. So this is one very strong piece of evidence that women and men don't differ in their response to very low nicotine cigarettes across 3 vulnerable populations. I also wanted to look at other trials. So this is a shout out to Joe Koopmeiners and Ziyu Ji at University of Minnesota, who did this meta-analysis for me. And what we looked at was in the trials from UVM or the Scenic Center, the trials that we pooled for this meta-analysis, which are shown here, including the Higgins studies. Is there evidence of a difference in response between women and men? And so these next slides are a little busy, but I will walk you through them. And I just want you to observe the general pattern. So this is the effect size for women. This is the effect size for men. This outcome is cigarettes per day. These are the trials. The bottom line is the meta-analysis effect size. So you can see just in general that this and this, they're about the same pattern of response, including in teens. That's the second to last row here. That's that trial, the only trial in adolescent daily smokers run by Rachel Cassidy at Brown University. These are the Higgins trials. No differences in women versus men. That trial in women with socioeconomic disadvantage, that's why there's no line for men. There were no men in that trial. The grayed out bars are the Hatsukami study that is currently under review. I didn't want to, pre-publish basically her results. So that's grayed out, but it's still included in the meta-analysis number. So what I want you to appreciate is there across those trials, there's no evidence for a difference, a systematic difference anyway, between women and men on cigarettes per day, on breath carbon monoxide level, which is shown here, on TNE, which is a measure of nicotine exposure. Effect sizes are smaller, but there's again no difference between women and men on nicotine dependence or on the wisdom measure of smoking motives. So I want to acknowledge limitations. Obviously, this is very preliminary, these analyses. I also want to acknowledge the limitation that these early studies, we asked one question, male or female. So we're doing that in a much more nuanced way in the current trials, but we didn't do that in this trial. So we left that for people to interpret as they would. And so that's a limitation. But based on these analyses, there seems to be basically no evidence or very little evidence for a difference between how women and men would respond to a reduced nicotine policy for cigarettes and other combusted tobacco products, which provides reassurance that women and men, and presumably girls and boys who smoke, would all benefit from a nicotine reduction standard. And I want to acknowledge Mike DeSarno and Joe Koopmeiners and Ziyu Ji at for doing these analyses for me on top of all of their other work. The scenic team, the UVM team, which I've had the pleasure of working with for the past 10 plus years, at least, on this work, and the research funding from the NIH and the FDA Center for Tobacco Products. Thank you very much.